Jack West, MD. I'm an associate clinical professor in medical oncology at City of Hope Cancer Center in the Los Angeles area, and also founder and president of GRACE. Isabel, can you tell us who you are and what you want?
Sure. My name is Isabel Preeshagul. I am a thoracic oncologist at Memorial Sloan Kettering, and I am very excited to be here today speaking to all of you.
And Joan.
Yes, hi everyone. I'm Joan Schiller. I'm a medical oncologist living now in Northern Virginia. I was formerly the deputy director of the Cancer Center at UT Southwestern and also of the Shar Cancer Center in Northern Virginia as part of Inova.
Excellent.
So glad to be with you.
We got a little bit of data, really not a lot, but a little looking at the question of what immune therapy can do for brain metastases. This study called Atezo-Brain was presented at the World Conference on Lung Cancer and gave carboplatin and Alimta, pemetrexed, along with atezolizumab, Tecentriq, in patients with untreated brain metastases. And in this, they saw a median progression-free survival of about 9 months, median overall survival of about 13 months. And you could see that the patients had a median intracranial progression-free survival of about 7 months and responses of these untreated brain metastases of 40%. Now, again, we can't know how much of this is chemo versus immune therapy, and this allowed any degree of PD-L1. My impression is that kind of like EGFR and ALK, where we've had therapies that can be terrific in the brain, they only work for the patients who are well selected for those targets. You have to have an EGFR mutation or an ALK rearrangement. You can't just give those inhibitors to unselected patients. My sense is that immune therapy is likely to be very effective in the patients who are going to respond well throughout the body to immune therapy, mainly those with high PD-L1. This didn't restrict to that. And so, I'm interested in what your thoughts are about your level of confidence about holding off on radiation for patients with brain metastases in hopes of getting a response from immune therapy or chemoimmunotherapy, particularly if they don't have a driver mutation, and how much or how little do you care what their PD-L1 expression is? If I can start with you, Joan.
Yeah, so I think those are all good questions, Jack. Unfortunately, we don't know, or at least I don't remember from the presentation, how many patients were PD-L1 positive or not.
There wasn't much discussion of that, as I recall.
Yeah. So nevertheless, though, that I think the numbers look good enough that I think I would feel comfortable potentially delaying cranial radiation for those patients who otherwise have a good performance status, have a decent PD-L1, and are asymptomatic.
So would that be PD-L1 positive? Does it need to be 50%? Or are you just going to take it case by case?
Case by case, but also I think we will be getting that data. They may not have had a chance to report it or have looked at it yet, but I'm assuming and hoping that we will get that data from the study.
Isabel, what's your thoughts? Is there any prevailing practice at Memorial?
I also would like to see the PD-L1 stratification, but one thing that makes me perhaps pause about this is the fact that the patients were able to be started on dexamethasone. So if they were on dexamethasone before they were enrolled in this trial, are they asymptomatic because the steroid has now made them asymptomatic? And would the dexamethasone decrease the efficacy of the atezolizumab? I know there was some work that was presented at ASCO actually by one of my colleagues, Dr. Arbour, and she did say that prednisone 20 and less did not decrease the efficacy of immunotherapy. But I'm just curious about the timing of the start of dexamethasone and the enrollment in the study, and if they were symptomatic before and now asymptomatic. because I wouldn't want to withhold intracranial radiation for a patient if they were symptomatic prior to starting dexamethasone. But if they truly are asymptomatic, then I think it would be okay. But another thing that I would want to know is, why are they on dexamethasone? Was it because of, massive edema? Typically, we put patients on steroids if they are having edema or if they're having symptoms. And the variations in how much steroid we use is also based on which radiation oncologist is seeing them, which neuro-oncologist is involved in the case. So I think I need to look through this with a little bit more of a fine-tooth comb before putting any patient on.
Excellent. Thank you.